Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We pick up on this midnight edition book reading of this beautiful full moon. Amazing. See, Pisces is such a big constellation. Yeah. And it's floating through there. It's right next to Saturn and Neptune. Peace. Peace, YouTube. Hi, it's Heart Love. Welcome. I'm your moderator and narrator, Uriel Riley. All right, we pick up in chapter 20, page 311. All right, we're in it. Pulmonary pathophysiology leading to acute respiratory failure. Again. Pulmonary pathophysiology leading to acute respiratory failure. Rationale for supporting inadequate gas exchange at the pulmonary level must be based on some schema that allows multiple factors to be evaluated and treatment modalities to be monitored in an organized fashion. Pulmonary function criteria provide a convenient and well-established base upon which to build a rational, logical, and practical schema for approaching the common pulmonary pathophysiologic pathways of acute respiratory failure. Following is a brief review of the basic pulmonary physiology and pulmonary function factors essential to our schema. These factors have been discussed in detail in chapters 3 and 4. Airway resistance accounts for a major portion of the normal work of breathing. Gross changes in airway resistance may be reflected in expiratory flow spirometry, e.g., FEV, MMEFR. In addition, regional differences in airway resistance may dramatically alter the distribution of ventilation. Lung and chest wall compliance are major factors in determining 1. The transpulmonary pressures required to inspire a given tidal volume. 2. The work of breathing. And 3. The FRC, vital capacity, is a gross reflection of ventilatory reserve. Total lung capacity is comprised of 4 lung volumes and is measurable in the pulmonary laboratory in a cooperative patient. Peace. Hi, it's Heart Love, Abrian. Hi, it's Heart Love. Thank you, YouTube. Thank you for reading books with us. Super high level. Here we go. Functional residual capacity. We're starting off on chapter 20, page 311 down at the bottom. FRC is the combination of residual volume, RV, and expiratory reserve volume, ERV. It represents the end expiratory lung volume and thereby the lung volume at which inspiration must begin. FRC is measurable without requiring the patient's active cooperation since it is non-effort dependent. This factor makes the measurement reasonably reliable in acutely ill patients. Presently, the bedside measurement of FRC is a research tool. However, new technology and methodology may well provide for routine bedside measurement in the future. Top of page 312. FRC may reliably be used as a direct reflection of total lung capacity since 1. A decreased FRC almost inevitably reflects a decreased TLC, and 2. An increased FRC must probably reflects an unchanged or increased TLC. Thus, acute obstructive or restrictive pulmonary pathology may be grossly diagnosed and evaluated via FRC measurement. Acute decreases in FRC have predictable effects on compliance and V over Q relationships. See Chapter 4. As FRC acutely decreases, 1. Lung compliance decreases. 2. V over Q imbalance occurs. Increased dead space and shunt effect. Big time. All right. Obstructive lung disease. Increased total lung capacity and decreased expiratory flow rates are the hallmarks of obstructive pathology. The common denominator is increased airway resistance from which exhaled gas flow is impeded to a greater degree than inhaled gas flow. The resultant increase in FRC, air tapping, leads to an increased lung compliance. Acute obstructive pathology, asthma, bronchitis, bronchiolitis is believed to be the most common acute pathologic pulmonary process encountered in the United States other than pneumonia. These diseases are usually self limiting and seldom life threatening. Treatment is primarily pharmacologic, i.e., bronchodilators, antibiotics, and vasoconstrictors, and anti inflammatory agents. Acute obstructive pathology is an uncommon cause of acute respiratory failure. Chronic obstructive pathology is usually a combination of emphysema, loss of lung elastic tissue, and alveolar septae. See, yeah, and chronic bronchitis. Most common in elderly patients, chronic obstructive pulmonary disease, or COPD, represents a significant diminishment in pulmonary reserves and may result in chronic respiratory failure. See Chapter 32. In terms of respiratory care, these patients must be viewed as having a tenuous baseline function and may not be able to maintain homeostasis when confronted with acute pathology. They require careful monitoring and early therapy. With COPD, acute respiratory failure may result from any physiologic stress and commonly does. Restrictive lung disease, bottom of page 312. Decreased total lung capacity and decreased vital capacity are the hallmarks of restrictive pathology. Chronic restrictive abnormality is usually the result of some form of pulmonary fibrosis or chest wall abnormality. These patients must be considered at high risk for acute respiratory failure when confronted with an acute pathologic stress. Top of page 313. Acute restrictive lung disease. Acute restrictive pathology is by far the most common pulmonary cause of acute respiratory failure in the United States. It has been our experience that more than 80% of potentially salvageable patients requiring acute respiratory intensive care have an acute restrictive pathologic process. The common denominator of acute restrictive pulmonary pathology is an acutely decreased functional residual capacity. Ding! The common denominator. Decreased functional residual capacity. For all those taking notes, all those reading along, and in the replay and playlist, clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, Carole A. Trout. We are in the 20th chapter, page 313. Certain generalizations pertaining to acute restrictive pathology may be stated as follows. 1. Decreased compliance of the lung thorax complex must be present, and therefore the patient's cardiopulmonary system must provide for an increased work of breathing. 2. The vital capacity is acutely diminished. However, the degree to which the vital capacity is affected is highly variable. Therefore, varying degrees of ventilatory reserve exist in patients with acute restrictive pathology. 3. Ventilation perfusion relationships are always abnormal, but the composition of these imbalances, i.e., dead space and shunting, is highly variable. In summary, any acute restrictive pulmonary pathology will lead to some increased work of breathing, some diminishment of ventilatory reserve, and some inefficiency of pulmonary gas exchange, V over Q imbalance. It is the combination of these adverse factors that so often leads to acute respiratory failure. Peace, YouTube. Thank you so much. Hi, it's Heart Love. Yes, Ash. That's what we doing here. The light workers. Thank you guys. Thank you. We're pushing towards 600 subs on this peaceful part of YouTube where we read books and learn from masters. So we're in the masterful part of chapter 20 of this book. We just started off. So we're reading through. We're at page 313. Thank you so much. In the playlist, I'll put the vocabulary in the playlist as well so that you can basically look up the words that you don't know and go through the processes with us. It's super high level, I know. And that's what like cause we do, right? Read to the people, give them solutions to master thyself. Master thyself, we can help the others around us. So welcome to this peaceful part of YouTube. Thank you so much. Here we go. 3 variations of acute restrictive pathology. Bottom of page 313. There appear to be 3 separable types of acute restrictive pathology commonly confronted in critical care medicine. Figure 21. 21. All 3 have decreased total lung capacities, vital capacities, and functional residual capacities. However, they differ in the degrees to which various lung volumes are affected and thereby manifest very different therapeutic requirements. Equal diminishment of all lung volumes. It says, refers to C figure 21. 1. Type A. This may occur in the presence of a normal lung or be due to primary lung pathology. In either case, both vital capacity and FRC are diminished significantly. When primary lung pathology is the cause, there is usually a significant true shunt, refractory hypoxemia that compounds the stress. The most common pulmonary pathology causing this type of problem is atelectasis. Atelectasis, right? The most common non pulmonary pathologies are 1. CNS depression, 2. Neuromuscular disease, as in like ataxia, right? Or MS. Yes. Thank you so much for reading along. Peace, YouTube. What's going on? Thank you so much. Live from the light. All right, so figure 21, bar graphs of the three types of acute restrictive pathology commonly confronted in critical care medicine. RV equals residual volume. ERV equals expiratory reserve volume. VT equals tidal volume. IRV equals inspiratory reserve. Yeah. Volume. FRC equals functional residual capacity. VC equals vital capacity. Type A equals equal diminishment of all lung volumes commonly seen with acute atelectasis, CNS depression, and neuromuscular disease. See text. Type B equals major diminishment in vital capacity commonly seen in the postoperative patient. See text. Type C equals major diminishment in FRC, commonly referred to as the adult respiratory distress syndrome or ARDS. See text. All right, here we go. So you'll see normal with full capacity of the IRV, VC, VT, ERV, FRC, and RV. Then you'll see type A again, which is equal diminishment of all lung volumes commonly seen with acute atelectasis. Then B, which is major diminishment of vital capacity commonly seen in the postoperative patient. And then C, which is the FRC commonly referred to as the adult respiratory distress syndrome or ARDS. Thank you so much for being here. Thank you for the likes and subs. The peaceful part of YouTube where we read books and learn from masters. And right now, we're in chapter 20 of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So there you go. There you see the bar graphs. Second edition, 1979. Peace, Ash from Australia. Highest heart love. Much love to all the beautiful beings and light workers here. Thank you so much. Much honor. All right. So, atelectasis, as we've spoken about before earlier in this book, but going a little deeper here in chapter 20. The collapsing of lung tissue is defined as atelectasis. When this occurs in a random pattern, patchy, or miliary atelectasis, it is not discernible on chest X-ray. However, most atelectasis of clinical concern involves contiguous areas of lung, usually segments or lobes, and is readily discernible on chest X-ray. When lung is externally collapsed, it is termed compression atelectasis and is usually secondary to pleural fluid, pneumothorax, or space occupying lesions of the thorax. Primary therapy of compression atelectasis is usually of a surgical nature and does not directly involve respiratory therapy techniques. Absorption. Atelectasis is the most common type of acute lung collapse and is usually due to retained secretions. See Chapter 8. Pooling of secretions exists not only in major airways, but also in the bronchioles. Yes, and small bronchi. The latter are poorly mobilized with bronchoscopy and or segmental suctioning. Therefore, bronchial hygiene techniques of respiratory therapy are the first line of defense in the prevention and treatment of absorption atelectasis secondary to retained secretions. Refer to section 3, which we talked about. All right. Top of page 315. Segmental or lobar collapse results in an acute decrease in TLC, even though eventual hyperinflation of adjacent lung is common. In the majority of cases, there is reasonably uniform infringement on the various lung volumes, although there is decreased pulmonary blood flow to an acutely collapsed area of lung. There is by no means a total absence of blood flow. Whew, key right there. This results in a true physiologic shunt, unventilated, perfused lung. The arterial hypoxemic effect of such a shunt will depend on the amount of blood traversing the shunt units and on the oxygen content of the pulmonary artery blood. The hypoxemia of true shunting is poorly responsive to oxygen therapy. See chapters 6 and 7 and requires significant compensatory work from the cardiovascular system. This partially explains why acute atelectasis is usually accompanied by tachycardia, mild hypertension, and tachypnea. Acute atelectasis secondary to retained secretions is a common problem in critically ill patients. The atelectasis decreases both blood and lymph flow in the area, thereby hindering two major defense mechanisms for preventing infection. Woo! Ding! Thank you. So beautiful. Mm, mm, mm. Gotta let it breathe sometimes, right? That's what we come to this peaceful part of YouTube for, right? You know you're gonna be able to breathe and just brace it in. Mm, 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 mm. In addition, pooled secretions are rich in nutrients, sugars, and proteins, essential for bacterial growth. The inevitable result of stasis, pneumonia, a serious and common complication of critically ill patients. CNS depression. Very key right here. Thank you so much for the likes and subs. Hi, it's heart love, much love. Thank you for reading with us these masterful books. I will put the vocabulary in the um, description when it's complete uploading. Thank you so much for reading here and being in this beautiful full moon energy, super full moon coming to us live from the light. And it's so beautiful to walk outside after knowing you've given a service to the people and say, I played my part. Thank you. The center grounding of this love by the Most High, the Allah, the eyes of the Most High. Mm. CNS depression. Obtundation of the CNS is commonly due to one, primary CNS disease, two, drugs, three, hypoxemia, and four, diminished cerebral perfusion. The obtundation generally results in one, diminished CNS response to ventilatory stimuli, two, ablation of the periodic variation size of normal breathing pattern. Yes. And three, diminished stimulation to the diaphragm and intercostal muscles. These factors are believed to lead to hypoventilation and decreased chest wall and diaphragm muscle tone, which results in acute restrictive pathology with all lung volumes fairly equally diminished. Since few alveoli actually collapse and lung is not primarily disease, arterial oxygenation is readily maintained with minimal supplemental inspired oxygen. In addition to the restrictive pulmonary pathology, a potential threat to all obtunded or unconscious patients is aspiration and upper airway obstruction secondary to interference with the airway protective reflexes. See chapter 33 and 34. An inescapable conclusion is that basic principles of acute respiratory care are applicable to all unconscious and obtunded patients. The expertise with which these techniques are applied may well be the most important aspect in supportive care of the unconscious patient. Airway evaluation, adequate oxygenation, and ventilation must be assured. Steps to prevent atelectasis and early treatment of lung collapse are essential. So key. And it has an exclamation mark there for it. So thank you so much for reading with us. Hi, it's Heart Love. Awesome. Oh, yeah. This is the high vocabulary part of YouTube. The peaceful part. Light workers, thank you so much for being here and reading with us. It's a beautiful thing, right? Only the masters level, masters corner, right? The best of the best. That's why people tune in and you know, you're gonna get mastery. Thank you so much for reading Masterful Books with us. Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Yearbook Medical Publishing, 1979. Thank you so much. Neuromuscular disease, right? We uplift the people here. Yeah. I know that some people, they don't like mastery. So they don't like peace. They have horrible lives. They speak those into existence. So they want to put that on other people. And this part of YouTube, we lift the people up because we're real life. Superstars. We're real life healers, real life light workers. So, like me, I'm the master of the 322 pressure points, right? I've been tested. And that means I almost took his life away. you know, splenius cervicus. Yeah, all I need is one finger. so, that's why it's powerful that we love on one another because I know what I can do. I know if I were to see cowards in real life, they will run away. They would be scared. They would know that's the real deal. I can take your life away with one finger, or I can heal you. And see, that's what I learned to do with this power, is heal the people. You don't want to hurt the people. That's too easy. Well, you uplift the people. You want to see the tree grow, right? Neuromuscular disease. Disease processes that temporarily or permanently weaken the ventilatory apparatus will initially result in a diminished total lung capacity that uniformly affects all lung volumes. Table 21 outlines the most common neuromuscular disease entities encountered in the United States. Such patients often have potentially reversible disease. They present a great challenge in respiratory supportive care, especially ventilator, yeah, ventilator care. The goal is to maintain clear lungs throughout the disease course. Close monitoring of ventilatory reserve and airway competence allows appropriate and timely intervention. Aggressive prophylactic pulmonary care may often prevent the need for ventilator support. Yes. All right, here we go. This is Figure 21, Type B. All right, it says Table 21, neuromuscular diseases commonly requiring respiratory intensive care. And it shows one, spinal and spinal cord disease, A, trauma, quadriplegic, two, paraplegic, B, polymyelitis, two, motor nerve disease. A. Acute idiopathic polynuclease neuritis. 1. Guillain-Barre syndrome. Mm, mm, mm. Wow. Has it right there. This is 1979. Whoo! Wow. 2. Landry's ascending paralysis. B. Tick bite paralysis. C. Porphyria. Porphyria. 3. Myoneural junction disease? A. Myasthenia gravis. B. Myasthenic syndrome. 4. Muscle wasting disease. A. Muscular dystrophy. B. Congenital, congenital myotonia. And 5. Tetanus. Wow. Wow. Here you go. Figure 21. Wow, I had it back here back in 2000. We're in 2025. Look at this information from 1979. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harris, and Carole A. Trout. Second edition. Wow. That's deep. Thank you so much for reading books with us. Thank you for being in the peaceful part of YouTube where we read books and learn from masters. Thank you so much. I'm Master Fitness Trainer Uriel Neville Riley. Highest heart love to all my family and friends, all the M techs, all the OR techs, and doctors and nurses. We love you so much. Thank you so much for all you do, healing the people. When lung remains free of pathology while an injury or insult is sustained that limits movement of the diaphragm and or chest wall, and acute restrictive pathology results in which the vital capacity is dramatically diminished while the residual volume is minimally affected. This would lead to an increased work of breathing attributable to the decreased ventilatory reserve and to some degree of V over Q imbalance due to the decreased FRC. A mild hypoxemia shunt effect is present and responsive to moderate increases in inspired oxygen. This pathophysiology is most commonly encountered in patients following abdominal and thoracic surgical procedures. This is discussed in detail in Chapter 31. Middle of page 317. Major diminishment of FRC. Significant decreases in lung compliance result in a severe restrictive pathology. Total lung capacity and vital capacity are significantly diminished. However, the greatest insult is the diminishment in functional residual capacity. This type of primary decrease in lung compliance results in profound increases in the work of breathing and profound V over Q imbalance, true shunting, shunt effect, and dead space ventilation. Since RV and ERV are so greatly affected, there exists a far better IRV, and therefore vital capacity, than would be anticipated for that degree of restrictive pathology. Thus, the ventilatory reserve is better than expected for the degree of restrictive pathology present. The clinical manifestations are: 1. Refractory hypoxemia; 2. Increased work of breathing; and 3. An excellent ability to achieve the increased work necessary to maintain adequate or low PaCO2. This type of acute restrictive pathology is commonly encountered as the adult respiratory distress syndrome, ARDS, and is discussed in detail in chapter 30. Woo! We completed chapter 20 on one read. Thank you so much for reading here. Oh my goodness, look at that. And completed section 3. Next, we will be going into section 4, airway pressure. Wow. That is amazing. We did it. Completion of page 317 makes for completion of this reading, chapter 20 of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Thank you for joining us at the intellectual, peaceful part of YouTube, where we honor all our friends and family, the ones that came before us, to give us these spaces to be able to master thyself. When we master ourselves, we can heal ourselves. When we heal ourselves, we can help heal the others around us. Oh, it's very beautiful to be able to share this peace with you that we've cultivated. Thank you so much for this beautiful full moon. So grateful and thankful. The light is shining so bright. So grateful and thankful for all I have now and all that is coming to me. Thank you so much. Thank you so much. Peace, peace, you two. Let's have a glass of love water. Love thyself, heal the people, right? Respiratory care is so important. That's why diaphragmatic breathing, assisted stretching, and pressure points to the hands and feet, aka your healing, has been such a bright light in the world. I will be publishing the book on it soon. So, highest heart love. I'm going to just let out a rash of new healing modalities for the people. You deserve it. We deserve it. I love you so much. I love you. Thank you so much for being here. Mm. I love you. 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 That is so great. Highest heart love. Thank you so much for reading with us. Have a wonderful evening. Oh my goodness. All right. We're going to the pink cloud tonight. So I will see you in the pink cloud. You have some work to do tomorrow. I'll see you in the pink cloud. I love you. I love you. You know it because I love myself. Thank you for being here. Thank you, Patrick. Highest heart love. Peace, peace. I'll see you soon.